Thank you, sir. Thank you.
Hello and welcome to the guideline session on preoperative investigation from the Indian Society of Anesthesiologists. I am Dr. Umesh and I feel really privileged and honored to present these guidelines. I would like to thank the office bearers of ISF LRE branch for giving me this wonderful opportunity to present the guidelines. Hello and formulating these ISF guidelines actually the brainchild of Dr. Anesthesiologists. I am Dr. Basqui's vision of bringing uniform guidelines for preoperative investigation that resulted in persuading the President and Secretary of Indian Society of Anesthesiologists to formulate a core committee of 7 members for formulation of these guidelines. And I feel really privileged to be a part of this core committee team. And from the core committee, an expert committee was constituted, which involved anesthesiologists who are subject experts from various parts of the country.
Sir, there is no audio. Sir, audio ಬರ್ತಾ ಇಲ್ಲ.
Balabhaskar sir, we can't hear the audio, sir. Maybe in the YouTube, the audio needs to be increased.
ನನಗೆ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ಸರ್.
Scenarios.
Can I interrupt, please? Are you able to hear the audio? Is everybody able to hear the audio?
Illa Bhaskar,
Yes, now it was audible, sir. Just now.
Okay, means my speaking you are able to hear.
Yes, sir. I can hear.
But your voice, so you can start doing afresh, Umesh, from your laptop.
Shall I put the same video, sir?
No, that also can be done, or it is left to you.
Okay,
You can start sharing from your side.
Fine,
Let us see about the audio problem.
Fine, sir.
Please. Sorry for the
Will you allow me to
yeah, please.
share the screen, sir?
Yeah, please. You can do now. Yeah, we can see.
Can you hear, sir?
Yeah, you can please start. Yes, please. You can start.
Am I audible, sir?
Now you are audible.
No, sir. In the video which is shared.
No, video, there is no voice.
Okay, sir. But the video is visible.
Visible, or you can straight away share the PPT itself.
Right, sir. Yes, sir. Still not heard, no, sir?
No, only your current voice is heard.
Okay, fine, sir. Then I'll just present it directly.
Ah.
Okay, right, sir.
Please make it full screen and you can start.
Yes, sir. Yes, sir. I'm audible now, sir?
Yeah, perfect.
Okay, fine, sir. Yes, sir.
Thank you.
Hello, good evening, everyone. I'm really sorry for the interruptions that we had for some technical reasons. I am Dr. Umesh, and it's a great honor and privilege for me to present the preoperative investigations guidelines from the Indian Society of Anesthesiologists. At the outset, I would like to thank the office bearers of ISA Bellary branch for inviting me for this session. The formulation of ISA guidelines was actually a vision of Dr. Balabhaskar sir. Actually, he was the one who initially visualized that there is a need for bringing guidelines from the Indian Society of Anesthesiologists. So there were a lot of guidelines available from other countries. Our country is very much unique, and therefore it really required our own guidelines. So he emphasized these facts and convinced the then president and secretary of ISA way back in 2017-18. And then with their help, sir constituted a core committee of 7 members. And I am fortunate to be part of that particular committee. And the core committee for each guideline prepared a group of experts and called it the expert committee. And for preoperative investigation guidelines, we have 16 subject experts who are spread across the country. They were, people of academic interest and value, and they have been handpicked by sir, and they represent all parts of India. So there were 16 subject experts and 1 biostatistician included in the expert committee. And with the help of the expert committee, core committee initially framed 10 important research questions regarding preoperative investigations. And then for each research question, a group of 2 to 3 experts was allotted to do literature search, and then if possible to do systematic review and meta-analysis. And after summarizing all these things, guidelines were prepared. So the core committee consisted of Dr. Balabhaskar sir, Dr. Harsu sir, myself, Dr. Rakesh Garg, Dr. Zulfikar Ali from Kashmir, Dr. Rakesh Garg is from AIIMS New Delhi, Dr. Sudesh is from Bangalore Medical College, and Dr. Pradeep is from ESI Hospital in Bengaluru. And apart from us, the current president of ISA and secretary of ISA also form part of this committee. The expert committee had 16 subject experts and 1 biostatistician, and their names are given here. To begin with, we needed to have a set a standard for why we want these guidelines. What is the purpose of guidelines? So we declared a preamble from the core committee, and the main purpose of the guidelines is that we needed to bring in uniformity in the ordering of investigations across the length and breadth of our country. We know that this is a country which is vast with a lot of demographic, geographic, socioeconomic variability. And infrastructure also varies from place to place. There are small setups like nursing homes or primary healthcare centers where some surgeries are conducted, to apex institutions and corporate hospitals and super specialty hospitals are also there. So there is a widespread variation in the practices of ordering of preoperative investigations. Many a times it was also either because of lack of knowledge or because of apprehensions of medical legal issues. So we from the preoperative investigations committee, we wanted to bring in one uniform ordering of these preoperative investigations across the country without having this facing this apprehensions of medical legal aspects. And also we needed to keep in mind that even at the primary health setups also, these will be applicable and they can be done. So with that emphasis, the target surgical patient population was ASA physical status 1 and 2 patients scheduled for elective surgical scenarios, mainly minor, intermediate, and major surgery. And for these guideline purposes, we have excluded specialty surgeries such as neurosurgery, cardiothoracic surgery, vascular surgery, and transplant surgery because they require a separate set of investigations which may not be applicable for other kind of surgical population. So they will require their own separate guidelines possibly, and they have their own associations also. And the main objective of this guideline formation was to have evidence-based structuring of what minimum recommended investigations that we can come to in conclusion. And these investigations had to influence the perioperative outcomes in some way or the other in this set of patients, or they should at least alter the anesthetic management plan based on the investigations. So that was the main purpose. And the other important factor here is attending anesthesiologist has to take the full and complete responsibility. Why we say so? It's because there may be a practice where one anesthesiologist evaluates the patient and orders the investigations based on the understanding of that anesthesiologist. And few days later, the patient may be scheduled for surgery where the attending anesthesiologist will be a different person. So it is the responsibility in the end of the attending anesthesiologist to have a proper a review of the history, clinical evaluation, the medications, and the lab investigations of the patients, and if necessary, to order further investigations. Now, these guidelines are mainly applicable for ASA physical status 1 and 2 patients, but that does not necessarily mean that we just go by the guidelines. It is important that they cannot be substituted for good clinical judgment. So every patient needs to undergo a detailed history taking, clinical evaluation, review of medications and previous reports. And based on that, subsequent judgment of ordering any additional investigations, if necessary, needs to be taken by the attending anesthesiologist. Now, when we say ASA2 population, specifically, they will have a certain comorbidity. Now, based on that particular comorbidity, how severe it is, and any particular investigation needs to be done for that particular comorbidity, that decision will be left to the discretion of the attending anesthesiologist. And for patients beyond ASA physical status 2, they are not fit to undergo elective surgical procedures. And therefore, because they have severe systemic illness, and therefore, they need to be referred to specialists for consultation and optimization. And therefore, the specialist determines what further investigations need to be done, how often it needs to be repeated till the patient is deemed fit to undergo elective procedure. Therefore, we did not bring guidelines related to ASA 3 and above. And when it is related to emergency surgery, lot of variations may be there in the patient condition itself. One patient may be having altered physiology to a great extent, while the other patient may be having altered physiology to a minimal extent. So that depends on patient to patient, and it varies from scenario to scenario. Similarly, one surgery, like say for example, if it is a debridement, yes, we can wait for 4-5 hours for the investigations to be ordered and the reports to be collected and then proceed with the surgery. On the other hand, if somebody is having a bleeding abdomen or is scheduled for perforation peritonitis, we cannot be wasting time waiting for the reports to come or some particular set of investigations mandatorily to be done based on the guidelines. And therefore, we again leave the discretion of ordering the investigations based on the patient physiology, urgency, and the available infrastructure in that particular setup. and also whether to await for the investigation reports to arrive before proceeding with the emergency surgery or not. This discretion is between the anesthesiologist and the surgeon based on the patient's physiology and the urgency of surgery. Now, the screening tests are not the focus of these guidelines. By screening tests, we say screening for viral markers or for identifying possible existence of diabetes or renal impairments. Those are not the objectives of these guidelines. When we have formed these guidelines, our main objective was that if we are ordering a routine investigation, there should be evidence that it is going to alter the anesthetic management or it may have some influence on the immediate perioperative outcomes. Only those investigations we will be suggesting through these guidelines. And regarding the pediatric age group, bariatric population and obstetric population, separate guidelines would be necessary because their physiology differs to a great extent from the surgical population which we normally encounter. And therefore, again, these are not part of our guidelines. Now, the main inclusion criteria for our guidelines preparation was all the studies that were published in full text in English language between 1st January 2010 up to 25th November 2021. All of them were downloaded and then they were screened for presence of ASA physical status grading. And if we had proper details of the patients related to ASA physical status 1 and 2 undergoing elective surgical procedures, again, non-specialty surgical procedures, only those studies were taken for analysis. Now, there are some exclusion criteria. Studies that had outcome variable as only cost analysis, they were not included for our systematic review. Now, studies which did not mention the ASA grading or did not give specific information to the subset of population, to the ASA 1 and 2 specifically, they were excluded from analysis. Then studies which addressed specialty surgery or emergency surgery, they were also excluded. Now, when I told you initially we framed 10 research questions and then 2 to 3 experts were allotted for each research question. Now, using specific search words, lot of literature review was done through websites, Medline, Google Scholar, Embase, and Cochrane Library. And then we choose only those studies that are appropriate for systematic review. And then a systematic review was done. At this stage, we took help of Dr. Gordon Guyot, who is from Canada and who is the father of this grade protocol. So under his guidance and specific directives, we have developed the systematic review, and then we approach the biostatistician for possible meta-analysis wherever applicable. Now, these were the search strategies that were involved for collecting evidence through literature search. And the first hurdle that we had was, so if we want to bring the guidelines, we cannot be having uniform guidelines, uniform investigation ordering for all categories of surgery. So we had to categorize the surgeries into minor, intermediate, and major surgery. And for that, we thought we will do it based on expert consensus. So we collected commonly performed surgeries across our country, and about 30 to 40 prototype examples were collected from the core committee, and that was given to the experts through an anonymous Google Form survey. And experts were supposed to divide them or categorize them into minor surgery, intermediate surgery, or major surgery based on the invasiveness of the surgery and the duration of the surgery. So these were the main criteria based on which the experts gave their opinions. Now, we didn't want one expert to be influenced by the opinion of the other expert, and therefore this was anonymous survey, and all 16 subject experts participated in the survey. Wherever there was an agreement about a particular surgery, say for example here we have fibroadenoma breast excision, it is written under minor surgery classification categorization because at least 12 experts out of the 16 experts agreed or felt that this should be a minor surgery. Similarly, when we say varicose vein stripping, at least 12 experts out of the 16 experts had opined that this should be intermediate surgery. So only when we had a consensus of minimum 75% agreement among the experts, we have given those examples. Of course, there is a very long list of procedures. If we try to analyze and put them into this category, we just wanted a list of examples for you to understand. For arriving at recommendations, a lot of virtual meetings. In view of COVID, we didn't have many physical meetings. Mostly, we had virtual online meetings in the Zoom platform. So, core committee, all seven of us, the members of the core committee, we met often and we interacted for almost 3 to 4 hours at each meeting. And we also held individual meetings with those 2 to 3 experts who are allotted one particular research question. And then we had a group meeting with all the 16 experts also at the times towards the end of the guidelines formation. Then we had several meetings with a biostatistician about systematic review and the meta-analysis. In addition to these things, we also had 2 meetings with Dr. Gordon Guyette regarding the systematic review and meta-analysis. Now, when we collected all this evidence, did the systematic review appropriately, finally, we had to establish the level of evidence for each study that is included in the systematic review. And then the systematic review itself had to be categorized into level of evidence. So whenever we had a high level of evidence or more than one moderate level of evidence, we could say that whatever recommendation that we are giving is strong in evidence, and therefore the word or the term recommended will be used in our guidelines. When the evidence was sort of weak because of a level of evidence was very low or low, then we use the term suggested. And unfortunately, for this preoperative investigation guidelines, there were no randomized controlled trials. So most of the studies that were selected for our systematic review were of low level of evidence or very low level of evidence. So for all the guidelines, we have uniformly used the word or the term suggested in the recommendations. So finally, when we made these recommendations, they were not final recommendations; they were draft recommendations. So the thing is, although meticulously we had reviewed all the literature and we had done a proper systematic review and we had analyzed it again and again before forming the draft recommendations, there was always a possibility that we could have overlooked something, and therefore we wanted to be very sure about our guidelines. So what we did was we followed a 3-step Delphi methodology, which includes, what we did was we 2 to 3 experts were given one research question. So they were very sure of that particular research question and that recommendation, but they probably had not gone through all the systematic review done for the remaining research questions. So we collated all this evidence and made into one document and we gave it to all the subject experts. So all the 16 subject experts went through systematic review for all the 10 research questions, and then they went through the draft recommendations, and then they were asked over a anonymous Google form survey to tell whether they will accept the recommendation or reject the recommendation, or they ask for clarification or revision, in which case they had to opt for review. So they had 3 options. So they went through all the scientific literature and then they gave their opinion about the recommendation. Now, when we collected this information from the opinion from the experts, again, we did not want them to be biased from the opinion of the others. So it was kept anonymous. So one expert did not know what was the opinion of the other expert. And when we pooled all the data, if we had at least 75% consensus, that is at least 12 out of the 16 experts either accepted the recommendation or rejected the recommendation, the draft recommendation was finalized. But if wherever there was less than 75% consensus among the experts, that particular research question and recommendation was modified as per the suggestions and clarifications sought by the experts, and that was taken to round 2. Now, in the round 2 of the Delphi consensus, it was the same methodology that was applied for the round 1. Again, an anonymous Google form survey where we had given the pooled opinion of all the experts and all the modifications the experts had sought without mentioning their names. This was given to the experts, and then they were asked to again say whether they would accept the recommendation, the modified recommendation, or reject the modified recommendation, or they still wanted a review. And if something remained unsolved at round 2, as in our case in these guidelines, the chest X-ray part did not get consensus among the experts. So we went for round 3 consensus. And this was an open round of consensus because we had only one area to be sorted out, where all the experts and the core committee members participated over a Zoom platform for a virtual meeting. And this issue was discussed, and then suitable modification for the chest X-ray recommendation was done, which was acceptable to all the experts and the core committee members. Then all the draft recommendations were considered finalized. Now, the first research question that we addressed, just 1 second, I have one. Okay. The first research question that we addressed was, in ASA physical status 1 and 2 patients who are scheduled to undergo elective surgery, will routine preoperative complete blood count testing change anesthetic management or patient outcomes after surgery? So this was the research question. And after reviewing the evidence, what we found was the complete blood count testing was done in 2 ways. Some authors or some literature evidence had the CBC divided into hemoglobin or hematocrit, total count and differential count, and platelets. Whereas some studies had only mentioning of complete blood count. They did not have individual parameters. So we did not know about in what way we can bring in the recommendation. But we did the nationwide survey of among the Indian Society of Anesthesiology practitioners regarding their practice patterns, and most of them felt they would prefer ordering complete blood count rather than individual tests. And therefore, the recommendation 1 is for complete blood count testing, and it is suggested to be done for all the patients undergoing elective surgery, irrespective of the type of the nature of surgery. Now, the second research question that we addressed was renal function testing. Now, renal function test, so normally we look for blood urea and serum creatinine. When we looked at the literature evidence and also looked at which is more favorable for renal function or more appropriate for renal function test, the blood urea can be altered when there is an underlying liver disorder. It may also be altered when the patient is dehydrated, and therefore it may not necessarily reflect the renal function always. And also, when we considered estimated GFR is also based on the serum creatinine value, and therefore we took serum creatinine as the marker for renal function test. So the guideline recommendations are based on serum creatinine values. So we have 2 recommendations over here. Preoperative serum creatinine estimation is not suggested for patients undergoing minor surgery. In fact, for minor surgery, when we reviewed, there were about 11 studies. So when we considered these studies, what we found was there were probably about 10-15 readings where the patients had 1.9 or 2.1 serum creatinine, although the patients were totally asymptomatic. Routinely, they had done serum creatinine estimation and they found that it was elevated in few patients. But the anesthetic management plan and the outcomes did not have any impact because of this. The patients underwent the surgery without any problems and they went home. And therefore, the recommendation is it is not suggested for patients undergoing minor surgery. Whereas recommendation 2B is for intermediate and major surgery, and this is suggested. Serum creatinine needs to be done preoperatively for patients undergoing intermediate and major surgery. Now, the third research question was related to serum electrolytes. Specific information was mainly available for serum sodium, and very little information was available for serum potassium. So we tried to bring in guidelines for these 2 electrolytes, which are commonly performed. The literature evidence did not show that they would impact either anesthetic management or the immediate perioperative outcome of these patients, and hence the recommendation is it is not suggested for patients undergoing any of these elective surgical procedures. However, we need to remember that suppose it is a ASA2 patient, say we say it is a hypertensive patient, and the patient may be on diuretic or maybe on AC inhibitors or angiotensin receptor blockers. Now, they may have an influence on the serum electrolytes. So, based on the medications or the patient condition or the surgical procedure, the attending anesthesiologist is free to order for additional investigation as per the need. Similarly, if a patient may be ASA PS1, but the patient is scheduled to undergo, say, transurethral resection of prostate surgery. Now, this surgery, we all know, involves irrigation of fluids, and this irrigated fluid will be absorbed systemically to a variable extent, and that may have influence the serum electrolyte values. And therefore, in such situations, again, the attending anesthesiologist should use the discretion to order serum electrolytes. Just because we say the guideline says it is not suggested doesn't mean that it should not be done for all the patient populations. That's what we need to remember. Now, the research question 4 is related to liver function testing. The evidence showed that for minor and intermediate surgery, doing routine liver function testing in asymptomatic patients who didn't have any illness suggestive of liver disorders, it did not make any changes to the outcome or change in the anesthetic plan. So, it is not suggested for those. However, for patients undergoing major surgery, liver function testing is suggested to be done in the preoperative period. Now, the research question 5 was addressing the coagulation profile. Though bleeding time, clotting time were used initially during our study period, nowadays with the advent of auto-analyzers and they are being available in most places across the country, coagulation profile essentially means prothrombin time, international normalized ratio, and activated partial thromboplastin time, and therefore we refer coagulation profile to PTA-PTT. So the recommendation is that it is not suggested for patients undergoing any of these elective surgical procedures. Again, here we have a rider. Say a patient has to undergo regional anesthesia procedure. Say central neuraxial block or some nerve block is planned with or without general anesthesia. For those patients, these patients may be on some medications which might have some influence on the coagulation profile, or the say some patient may be on Ayurvedic preparations and that may have some influence. So we don't know in such situations what to do. So for that particular category of patients, we request you to refer to the existing guidelines related to regional anesthesia and anticoagulation, and also to alternative system of medications, which may have influence on the coagulation profile. And our ISA team core committee with another set of experts is also working, and soon I think the guidelines will come related to the Indian guidelines will come related to coagulation, regional anesthesia and anticoagulation. When they become available, we can refer to those guidelines. The sixth research question was related to blood glucose. In a ASA PS2 patient who is a known diabetic, there is no doubting that their blood glucose needs to be done on the morning of surgery. We all know that. But we wanted to address the non-diabetic population among the ASA physical status 1 and 2 patients, whether that makes any influence on the anesthetic management or the outcome on the surgery. So when we say non-diabetic patients, patients are considered as non-diabetic if during our pre-operative anesthetic evaluation period, we take a proper history of the patient, we do evaluation, clinical evaluation, we review their medications and also previous investigations. If none of that is suggestive of diabetes mellitus, would doing a blood glucose will have any influence? No, it will not. And therefore, the evidence and also common sense dictates that in non-diabetic patients, preoperative blood glucose estimation is not suggested for any of the patients undergoing elective surgical procedures. Now, again, one point I need to emphasize here, we don't want to bring guidelines for screening tool for detecting underlying diabetes. That is not the objective of the guidelines. Research question 7 is related to 12-lead electrocardiogram testing. Now, again, if a patient has some cardiac comorbidities like hypertension, arrhythmias, ischemic heart disease or diabetes or long-standing COPD, then there is no doubt that they will require a 12-lead ECG testing irrespective of their age. But when it is a non-cardiac patient, again, non-cardiac means a patient whose history, clinical evaluation, review of medications and previous reports is not suggestive of anything related to cardiovascular disease, whether preoperative ECG makes any difference to immediate perioperative outcomes, or will that alter our anesthetic management plan, or the question that we wanted to address. So when we found the literature evidence, there is nothing suggestive that for minor and intermediate surgery, ECG needs to be done. However, we also considered the larger perspective and reviewed the cardiology journals and other public domain journals within India to see what is the prevalence of cardiovascular disease in our country. And we found that at or above the age of 45 years, the incidence of cardiovascular comorbidity is significantly increasing in the Indian population, and therefore we rephrased our recommendation 7A, which is preoperative 12-lead electrocardiogram testing is suggested at age 45 years and above when scheduled to undergo minor and intermediate surgery. For major surgery, it is suggested for all patients irrespective of age. Now, the eighth research question was addressing chest X-ray testing. So, chest X-ray imaging, when we do, it can be influenced by several factors. There may be active smoking, passive smoking. India has so much of issues related to pollution and prevalence of tuberculosis so high that at some stage, a lot of people would have had pulmonary tuberculosis as a pathology, but they would have recovered from that. Now, if we routinely scan chest X-rays for all the patients, we will find some minor pathologies here and there, but would they influence the anesthetic management or the immediate perioperative outcome in any way is what we wanted to know. So when we did the literature search, and we found that preoperative chest X-ray testing is not going to benefit in any way for patients undergoing minor surgery. Related to patients undergoing intermediate and major surgery, also we did not have significant literature favoring or not favoring this. So we had to have expert consensus on this particular issue, and even experts were not of common opinion. That's why it had to go for Delphi round 3. And in the end, the consensus was that chest X-ray preoperatively testing chest X-ray is suggested for patients aged 50 years and above for those patients who are scheduled to undergo elective, intermediate, and major surgery. Now, the ninth research question is related to ultrasonographic assessment of the airway. Nowadays, ultrasound is available across the country, and anesthesiologists are becoming more and more familiar and also skilled with the use of ultrasonography, whether it is in the ICU or in the emergency room or in the anesthesia room. Now, it is becoming a good armamentarium in the hands of the anesthesiologist. So, we evaluated the ultrasonography for its utility for airway assessment. We found 22 studies which are published in our study period, and among them 20 studies were in no doubt they were suggesting that preoperative airway assessment by ultrasonography is a better predictor for difficult laryngoscopy compared to any of the combination of clinical parameters that we routinely use. However, from these 20 studies, there was no consensus as to which one or two or three airway parameters by ultrasonographic evaluation would definitively predict the possibility of a poor laryngoscopy view. And because of that, and considering the practitioner's perspective that many centers still do not have ultrasonography available for anesthesiologists, and even where it is available, the anesthesiologist may not be familiar with its use, and they may not be skilled enough to do ultrasonographic airway assessment. The current recommendation stands that it is not suggested for predicting difficult laryngoscopy routinely. Now, the 10th research question, which has not been addressed by any of the guidelines present across the globe as of now, is related to validity time for preoperative investigations. By validity time for preoperative investigations, what we mean is, suppose a patient for some reason had undergone some laboratory testing or ECG or chest X-ray, and now after a month or several months is scheduled to undergo a surgery. Now anesthesiologist goes through those previous reports and is in dilemma whether to trust those investigations or order new set of investigations. If we order new set of investigations, would they be cost effective? Would they make any change in the anesthetic management plan or in the immediate perioperative outcome compared to what is already available? That is the question that we wanted to answer. And what we found was two very interesting studies which had addressed these issues. And one study had 235,000 plus population of ASF physical status 1 and 2 patients undergoing these minor, intermediate, and elective surgeries. And that recommendation definitely, those studies helped us to form these recommendations. So the acceptable validity time for a previously performed normal complete blood count or a normal renal function test or a normal liver function test or a normal coagulation profile is suggested to be 2 months, provided in the intervening period of 2 months from the time it was done, the clinical condition of the patient has not changed. That means patient has remained stable from the time previous investigation was done, and the time duration is less than 2 months from the previous investigation. And then in such scenarios, we can rely on the previous investigation. There is no need to repeat the investigation when the patient is scheduled to undergo a particular surgery, irrespective of the nature of the surgery. Recommendation 10B was related to ECG and chest X-ray. Now, the suggestion is that up to 12 months period is acceptable time for the acceptable validity time for ECG and chest X-ray. Again, provided the clinical condition of the patient has not changed in the intervening period. So now, this particular slide summarizes all the recommendations. The green colored boxes represent that it is suggested to do the particular investigation for different category of surgeries, and the amber colored boxes represent that that particular investigation is not suggested for that particular nature of the surgery. So for example, CBC is suggested for all types of surgeries, while renal function test is suggested for elective, intermediate, and major surgery. Liver function test is suggested only for elective major surgery. 12-lead ECG is suggested for minor and intermediate surgery if the patient's age is 45 years and above and is a non-cardiac patient. If it is cardiac patient, yes, it needs to be done irrespective of the age. And a 12-lead ECG for patients undergoing elective major surgery is suggested for all patients irrespective of the age. Chest X-ray is suggested for intermediate and major surgery patients whose age is 50 years and above. But if the patient is symptomatic and below 50 years, then yes, the attending anesthesiologist uses the discretion to order chest X-ray. That is fair. So with this, I would end this particular session. Thank you once again for giving me this wonderful opportunity to present the guidelines. If you have any queries, kindly ask me the questions. Thank you.
Thank you, sir. That was an excellent presentation and it's an exhaustive presentation. We have Harsur sir here, and he is also one of the
Core committee members.
Core committee member, along with Bhaskar sir. So we want their comments and then take the questions later, if any.
Good evening, Harsur sir.
Good evening, sir.
Good evening. Really excellent presentation, Dr. Umesh. I think you have made every point clear. Probably I do not expect any question from any among the audience. So much was the clarity from your end. I think right from the conception of this to the research methodologies and how we arrived at the recommendations. You have explained everything in detail. That's a really excellent presentation, I should say.
Thank you, sir.
So,
any other senior members are there, Bhaskar?
yeah, there are 50 people today on in the Zoom platform. Only thing is, definitely Dr. Umesh should be asked to re-explain, because many of the social media comments when we shared the publication was about the blood sugar. So people are a little bit, our colleagues basically, many of them felt that blood sugar should have been shown to be an important pre-op investigation. You can just, I think you did explain it. You can just inform once again to all the participants, Umesh.
Right, sir.
The blood sugar
So,
was not
yeah,
at
yes,
risk.
sir. Yes, sir. See, first of all, blood sugar, yes, if it is a diabetic patient, there is no doubt that it needs to be done during the preoperative period. That is clarified. When it is a non-diabetic patient, by non-diabetic, what actually we mean is when we take a detailed history of the patient, we do clinical evaluation of the patient, then we go through the previous reports of the patient and also any particular medications that the patient is on. When we review all these things, if nothing is suggestive in favor of diabetes mellitus, it's highly unlikely that doing that investigation will impact the perioperative outcome or anesthetic management plan. And therefore, the recommendation is that yes, it is not suggested in non-diabetic patients undergoing any of these elective case scenarios. And we again, one more important fact is we don't want to use it as a screening tool. That is not the objective of our guidelines.
I understand. So there is a difference between a screening test and a specific preoperative investigation. So that we must understand as practitioners. We also know that it is, for example, point of care testing is available, glucometry is available. But when we frame guidelines, it's basically based on the availability of clear-cut scientific evidences. So in the preamble itself, Dr. Umesh had clearly stated that these investigations should have some influence on the management and the perioperative outcomes. So if some of the test has got any of these effects, only then they will be either considered or not considered to be advised in the preoperative period. So that way speaking, in non-diabetic patients, based upon the multiple evidences that were collected as part of this project, we never had any data on the utility of preoperative blood glucose in non-diabetic patients, starting from minor to the most major surgeries also. Right, Dr. Umesh? So this is what, this is what all of us, our colleagues have to understand. And a screening test, yes, it is done, for example, by a private practitioner or incidental advice based on some history also. Even if somebody goes to a private practitioner, a general practitioner or a family physician, if somebody has got an infection or repeated infection, or there are some symptoms of diabetes only, that screening test is advised. So otherwise, no population, no individual would undergo basically a blood glucose estimation. So that is the reason we are not talking about the screening test in the preoperative period. We are purely talking about the preoperative investigations, which could have a bearing on the anesthetic management and the outcome in the postoperative period. So I think there are.
We have a lot of queries or suggestions related to diabetes again, sir, and blood sugar.
Yeah, you can just take up the questions one by one, Dr. Umesh. You can pick up from the chat box.
Yes, sir. So regarding again blood sugar, there are a lot of questions. Yes, see, again, I want to clarify that we don't want to use it as a screening tool. Somebody has definitely commented, and it was discussed and deliberated in almost 3-4 meetings with all the experts that, sometimes patients present for the first time to the hospital ever in their life, and it is an opportunity to pick up a possibility of underlying diabetes mellitus. But then we are also taking detailed history, doing clinical evaluation, and looking at the patient as a whole. And at that stage, if we feel that there is nothing suggestive of diabetes, when we do blood sugar estimation, even if it comes as 180 or 190, it is not going to make much difference to the perioperative outcomes. There are other associations who will be looking forward to this. There are public forums, and the government also is there, which is behind all these issues. It comes under their domain. As anesthesiologists, our target is immediate perioperative outcome, and if there is any change in the anesthetic management. So if we recommend or suggest that blood sugar needs to be done, irrespective of just because of the apprehension that first time the patient might have come, it is quite likely that out of some 5,000 or 10,000 patients, 1 or 2 may have some 150 or 250 sugars, but it will not affect the outcome anyway. So that's why we have brought this particular recommendation. And regarding HbA1c, yes, we did not want to get into that area because once a patient has diabetes as the comorbidity, that will be decided based on the comorbidity itself. When a patient is non-diabetic, we are addressing only that situation. So one more question is related to coagulation profile. They wanted me to clarify that. Yes, the evidence definitely points to the fact that none of these PT, APTT, INR, which are routinely done prior to elective surgery, has any influence on the anesthetic outcome or the anesthetic management plan. However, still, if we plan for even not just PT, APTT, INR, even for platelets, they may have influence on when we are planning regional anesthesia, especially central neuraxial block. So when we are planning regional anesthesia, we can refer to the guidelines related to regional anesthesia and anticoagulation. And according to those guidelines, we can plan whether a particular investigation needs to be done or not. But if a patient has some anticoagulant already, or patient is in sepsis, yes, the anesthesiologist can use the discretion and order for coagulation profile. In a person who is apparently healthy, it is not going to make any difference in our anesthetic practice.
There is this question from Major Vivek Patnam. This one for colleagues. Any clarity if elective cases can be cancelled because morning of surgery, repeat investigations such as serum creatinine in diabetes mellitus patients is not done?
Yes, when there is a comorbidity, we have not actually gone into that side because again, the attending anesthesiologist has to see to what extent it has influenced or impacted the patient's physiological status, and based on that, they will have to take a call depending on the nature of the surgery and depending on whether the patient's physiology would be impacted because that value was not done or it was slightly abnormal. Whether to proceed with surgery or not, that is to the discretion of the individual anesthesiologist. What happens is individual scenario will be significantly different from one to the other. So if we bring some common guideline, it would only result in a lot of disturbances.
Yeah. So one of the important statements we have made in the guideline is we must stick to the basics. A thorough history taking, clinical evaluation, and a review of the patient's drug history. So these three things are very important. Number one. So number two is, again, as you said, Dr. Umesh, any changes in the physiology and pathology. So these are the domains of the attending anesthesiologist. He can take a call based on that. So this is one which is part of the guidelines, and we cannot be giving 100% correct recommendations for many situations. And after all, we are the experts and we can decide also. And of course, Dr. Amit, you have explained about the coagulation profile, basically.
Yes.
Right? So whenever we are trying to do, for example, regional anesthetic technique, and if the patient is on drugs, either allopathic drug or even the native medicine, we have to refer to the specific guidelines of regional anesthesia and anticoagulants. So again, with respect to diabetes, there are questions. Basically, I think it is related to the screening. And Dr. Ravi Kerur, our colleague, has asked, in India, patient comes to hospital the first time. So probably he is referring to the screening aspect versus the pre-op investigations. What do you want to say, Dr. Umesh?
So that's what I clarified about that only. That these guidelines are not for to be used as a screening tool. There are other associations and physicians are there. They have their own associations, and government is there to take a call on that. From the perspective of Indian Society of Anesthesiologists, our objective is very clear. In the immediate perioperative period, will testing something in a patient make any difference in the outcomes for the patient, or it will alter the anesthetic management plan? As per that, we have done the evidence review, and it is the screening tests are not under the purview of our guidelines.
Okay. Then we have got Dr. Vishwanath Meti. Actually, we did consider in the group also. Sir, what about the serology screening? Or you can take it as testing also or screening. We had a clarity. You please explain to the
Yes, sir.
members.
We did debate with the experts. Actually, all the 16 experts actively debated and deliberated on this issue. Again, they felt that serology or even urine testing and for pregnancy testing, we did not want to enter into that domain because it is best left to the anesthesiologist discretion, and it can unnecessarily create medico-legal hassles if we give certain recommendations in these areas. And anyway, they are not going to make a difference in our in the patient outcome or the anesthetic management plan.
So especially the routine serology testing related to HIV, the hepatitis B and all, hepatitis C, that was discussed with the experts, and it's not going to affect the outcome. If somebody is really having the disease, we are going to take into consideration the effect on the organ systems. With respect to pregnancy, a conscious decision was taken not to take it up, even though it is part of some Western recommendations, guidelines, or statements. Because where they talk about any patient, female patient in the childbearing age, they were expected to talk about the pregnancy testing. So keeping in mind the specific socio-cultural aspects of Indian conditions, and keeping in mind the practice patterns among our own colleagues in India. So experts and the core committee decided that we will not talk about the pregnancy testing. So simply put, if I am a practitioner and if I go to a hospital and if I say a pregnancy testing is done, to be done, so definitely it will evoke a lot of emotional responses. So it is not advisable. And just to convey again, the guidelines which are prepared by us is wholly in keeping in mind the practitioners of anesthesiology in the Indian scenario, so that medico-legally also we are safe and strong. So there was HbA1c, RPSS screening. What about here? Can this be an evidence in consumer forum? It's one question.
Our guidelines, yes, sir.
Yeah. So this is both yes and no, in the sense the guidelines, yes, we have prepared very scientifically based on evidences. So they are practice guidelines of Indian Society of Anesthesiologists, thoroughly researched, and then the recommendations were formulated. So in fact, even whether it is a consumer forum or a court, whether it is civil or criminal aspect or whatever, it is the guidelines are one of the ways we can inform the court that we have done some evidence-based practice, that it is not my individual decision. So definitely, if I am the one who is got stuck in a medico-legal issue, I can clearly tell the court that we have got this type of guidelines, and based on these guidelines, I have acted. So courts will definitely take note of this. So in fact, to inform our colleagues across the country, so far, for so many years and so many decades, we did not have Indian guidelines. And there are instances when the court would ask, are there no Indian guidelines? Okay, so
most of the times court asks what is the evidence for your decision. This is the question often asked by the court.
Yes.
So you can say that these are the guidelines which were framed purely based on evidences. See, my liking or somebody's liking may be different, or my practice pattern may also be slightly different also.
Yeah.
But then, yes, these what we have prepared is based mostly on the evidences that are available in the published literature, and partly I think a couple of research questions are answered by our experts through Delphi method. So therefore, I feel if we convince the court that this is an evidence-based guidelines, they should be accepting. This is one point. The second point is these guidelines are mostly the minimum recommended investigations. Does not mean that a clinician, based on his clinical knowledge or the clinical situation prevailing in the patient at that particular point of time, there nothing bars him from doing it. The guidelines never prevent anybody from doing the further investigations as and when required. The basic assumption that is made is the patient is not having a particular disease, a known disease, or the history is not suggestive of a particular disease. This is first point. And second point is the particular investigation, even if it is something different, it is unlikely to alter the patient care or patient's outcome. These are the two factors in the outcome. So these factors are taken into consideration while preparing the guidelines. So therefore, this must be used as a bare minimum once, and beyond which any anesthesiologist by his clinical decision can escalate for higher investigations. But minimum, can you not avoid this? No, we don't say don't avoid these things. This is because it is based on evidence. This is what I can say.
Yes, sir.
Umesh?
Yes, sir. Absolutely, sir.
It's a perfect state. And Dr. Parimala has given more like a opinion. Most of the surgeons will do fasting blood sugar and random blood sugar in absolutely asymptomatic patients. It will be found to be a new diabetic patient, and treatment will be started accordingly. Once sugar profile is stabilized, then the case will be posted for surgery. So that would be definitely a practice of the surgeons. For example, if the patient has got an infective pathology or an abscess or something, or non-healing ulcer, so definitely they would take a call and they will advise mainly before the case is even posted. So that is definitely their discretion based upon the speciality. So that we will not enter into those things. And family history of diabetes, yes, we told already when we have thorough history, it is done. If we definitely have a strong suspicion, you are at liberty to decide on that also. Then,
Yeah, the issue is when there is no such history,
yes,
should we do it? If the patient is not giving such history of family history or any of the signs and symptoms suggestive of diabetes, for example, in such a situation, we suggest not to do it. But if history is there, definitely, yes, you are free to do that.
next, Dr. Vivek.
And let us not use this as a diagnostic tool to diagnose a patient whether he's having a diabetes or not. This is not out of, this is out of our purview. We don't want to do that. For the purpose of practicing the anesthesiology or anesthesia administration, these guidelines are made.
Yeah. So we are not going to diagnose, take up that role. Or you have got the package of laboratory testing, which is done in many corporate hospitals and many cities also. So they are totally out of purview from the pre-op investigation domain here. Dr. Vivek has asked Dr. Umesh, can these guidelines be quoted by surgical colleagues to not comply to case-based additional investigations advised by the anesthesiologist?
Sorry, I didn't understand the question, sir.
Can these guidelines be quoted by surgical colleagues to not comply to certain case-based additional investigations advised by the anesthesiologist?
No, sir. No, that's what we have very clearly defined, that these are the basic minimum investigations. But based on the history, clinical evaluation, and the reports and the medications of the patient, anesthesiology should take a further decision on ordering the investigation. And when the anesthesiologist requests for further investigations, the surgeon has to do them, because it is logic based.
It is. If anesthetist request for additional investigation based upon his discretion and assessment, definitely it has to be taken up.
Yes, sir.
So that has been made amply clear in the publication. Then Dr. Parimala has again expanded on that. Even with serum sodium, most of the times it will be low in asymptomatics and those who are not on any medications also.
Yes, sir.
Dr. Umesh?
And the outcomes don't differ. We end up giving anesthesia knowing that serum sodium is 125 or 126, and patient is conscious oriented, and it doesn't make any difference to the outcome or the anesthetic plan. That's why the recommendation is that it is suggested not to do it electively, just like that, as a routine investigation.
Yeah, that definitely we will agree, basically, because if we go out of, beyond the evidences, about 10 years ago, we were happy with a serum sodium of about 130 millimoles per liter. But subsequently, the evidences emerged that we must never allow the sodium to be even less than 140 millimoles per liter based on other evidences. Okay. So doesn't mean that somebody who is at around 130 millimoles per liter would be symptomatic. And this is an incidental detection, and it is not going to have any impact upon the management of the patient and the outcome of the patient based on the current evidences. So that has been clearly explained already. Then Dr. Srinivas has asked, what is the role of preoperative routine test for urine sugar, albumin, and micro?
Yeah, we considered those aspects, but in the expert group discussion, we actually eliminated this particular test, sir.
Yeah, I do remember we were talking about urine specifically. I also participated. So this, for example, did you have evidences, Dr. Umesh?
Yeah, I collected 3 studies in that.
No, what was the quality of the evidence?
No, see, it is a very simple investigation, totally non-invasive. It wouldn't cause any disturbance to the patient. If we do it, the patient will not be harmed in any way. But the outcome of that did not influence the anesthetic management or the perioperative outcomes. Evidence was not in favor of routinely doing this.
Routinely doing it. Okay, urine testing.
Yes, sir.
Okay. There have been cases decided against anesthesiologists regarding ECG for pregnant women when there was an event perioperatively.
Yeah.
So other area of concern being echocardiography. So one of the
Echocardiography is a specialist discretion. If we find that there is some abnormality in the ECG or the patient has something suggestive of cardiovascular comorbidity, we will be referring to the cardiologist, and then it is their discretion to do or not to do it.
ECG.
ECG we have discussed. Is there any doubt about that?
No, what they have
No,
put is
pregnant woman. It is
they have
pregnant woman.
yes,
they are asking.
Again, for pregnant women, we have not actually taken that into our guidelines because their physiology is different. But in this case, what I understand is they did not do preoperative ECG and there was some problem. Is that correct?
yeah,
Sir?
yeah.
Yeah.
Maybe proper history and evaluation of the patient was missed in that case. I don't know.
No, that could be the reason. So
Or it could be amniotic fluid embolism. Something might have happened intraoperatively, but preoperative ECG might not have determined the prognosis if it was done. I don't know. We have to go back to the history and evaluation and findings in the preoperative period for that particular patient.
So it's an instantaneous situation-based decision by the anesthesiologist. So if there had been again the symptoms and findings which are indicative of a requirement for ECG or echo, that could be taken. That call could be taken by the attending anesthesiologist. So anything, a failure or otherwise of the anesthesiologist would depend upon that particular situation. Then preoperative 2D echo. I think we have given the guidelines basically. That was a question from one of our, I think, trainees. Then major again, okay, Dr. Vivek Patnam has asked, is referral to cardiologist for anesthesia fitness a valid statement or any other special giving fitness to it? It is out of the domain of today's discussion, but still we can answer it.
I have actually typed the answer.
I think he has answered, yeah.
The fitness is decided by the anesthesiologist, attending anesthesiologist specifically. Others can give their opinion about the risk stratification of the patient and to what extent the patient can be optimized.
Yeah.
So based on that, if I am giving anesthesia, I have to decide which anesthesia I have to give and whether the patient will tolerate it or require further optimization. That is a discretion of only the attending anesthesiologist.
Patient on table for cesarean section without investigation, can we refuse?
Sir, actually, we have not addressed this, so I don't think we should be answering this question also.
Yes.
So, but hypothetically speaking, now, of course, one of our colleagues has asked here. So, sir, Arsu sir.
Yeah, well, I did not get the question.
No, one question was, patient is on the table for cesarean section without investigation. Shall we refuse? Means, can we refuse?
It's elective
It is a-
cesarean section.
Nature of an emergency procedure for any reason, depending on the situation, one has to take the call. But for an elective procedure, whatever basic where investigations are required, we have to do it.
Okay, so that's what is to be conveyed to our colleagues. If it is an elective procedure
Yeah,
and I am
but
going
not a
late
part-
and seeing the patient on table, it's my fault. For elective, sir.
It is our duty to recommend and get it done as early as possible. If the time is not permitting you, then it's a different matter altogether. You have to take the
It will be
decision.
recorded on the case sheet and then we can take forward.
Yes.
Only thing
Yes.
is record keeping is most important. You have to clearly enter that for this particular reason, we could not get the investigations done for the patient. And that's the reason the surgery is taken up. The recording is more important in many situations. Is it not, sir?
No,
Yes,
probably we can utilize the validity of
Previously done
we have
investigation.
not addressed this particular in our guidelines. There is what is called as a validity of our preoperative investigations are there. If it is say 2 months old investigation for a hemoglobin or something like that, so they can be useful, I feel.
Yeah. It's very good. I must declare that this is the best thing that has happened in our guidelines. Dr. Umesh has said it has not been addressed in other guidelines, basically. And this is a common scenario we face in our practice or in the institutions also. So we had sound support in terms of at least one study where there are almost 2 lakh patients.
2,35,000 plus.
35,000 patients. So based on this, definitely we could come to this type of recommendation. So for majority of the routine investigations like CBC and all, 2 months, if somebody has got a report of 2 months previously, that can be accepted. So even in with respect to the current question on cesarean section without investigation or something like that, we can base our defense telling that a pre-existing report is available and we can go ahead. And of course, again, it is important to document everything on the case sheet. Okay, there is some question from Dr. Vivek Patnam about ISA physical status grading instead of ASA physical status grading. Okay, that thought is already there since the last 1 year in ISA, that a suitable decision will be taken. Then Dr. Manas Khan, question is, whatever be the ASA physical status of a patient, we should not write fit for anesthesia. The idea of pre-op evaluations and investigations is to risk stratify and optimize depending on available time and to do necessary referrals for opinion and not to ask for fitness. What's the opinion of the house? Okay, it's just out of our domain, but I think very simple, commonly asked question. So we are never expected to ask for fitness as anesthesiologists. We are specialists and we have the knowledge and definitely mandate to decide whether a patient can be taken up for a particular procedure. We are always at liberty to ask for cross consultation and opinions if necessary. Okay. So there is no problem about that. So this is widely accepted. Only thing is for us to realize that we are the ones we can also decide independently. Should be deciding independently in majority of the situations. Next, Fakiresh has asked, is ideal necessary for patient for surgery around the neck to know about airway? Umesh?
Indirect laryngoscopy.
Yeah.
We have not considered for our guidelines preparation, but we consider that as expert consultation to do that as a evaluation. So yes, if you ask me, yes, my personal opinion is when surgery is in the territory of this recurrent laryngeal now, it is better to ask for that and document the functioning of the vocal cords.
So we also discussed many of the things. For example, indirect laryngoscopy is not taken as a preoperative investigation, first of all. So we did discuss about many things. So we narrowed on what are actually the pre-op investigations. Okay, so these included what we discussed already, the routine blood testings, the ECG, echo, and all were considered. So this is not part of the pre-op investigations. Then I think it's again antepartum checkup tests would be available. I think we'll not go into the details because they are specific to a particular pathological or physiological condition. Then finally, one question, routine 2D echo, again, the consumer forum has gone against the anesthesiology sadly, making it a routine in a few setups. Okay. So it's not what we discussed already. Sometimes or majority of the times, the fault lies with us because we don't document things properly. Majority of the times, 90% of the times, the medico-legal issues arise because documentation is not done properly. So without specific details of a particular case, we cannot comment. The general opinion is documentation is one problem. Second thing is, we have talked about in the guidelines, the discretion of the attending anesthesiologist to advise a particular investigation based upon the instantaneous condition of the patient. At that moment, what is the condition of the patient? Based on that, we can always advise. Am I right, Umesh?
Yes, sir. That's why we have specified in the preamble itself that these investigations should not be meaning that detailed history, evaluation, and looking at the previous reports and medications of the patient. We cannot base only on order investigations only based on the guidelines. Guidelines are just a starting point, and based on the actual findings of the patient and documenting all those things, if the anesthesiologist feels something is going to be useful for the patient or will identify some pathology or help in optimization, they should use their discretion to order that particular investigation or test.
So definitely, one or 2 points I can highlight to all our colleagues is with respect to chest X-ray. So especially many of us in 20, 30 years ago, Sir will also acknowledge that X-ray was very frequently advised those days, especially when we didn't have other modalities also with respect to some of the investigations. So what we have recommended is for minor surgeries, at any age, we don't advise X-ray. Only if we have got certain specific respiratory symptoms and signs and on examination you find something, we are going to advise. Otherwise, routinely for minor surgeries, chest X-ray for any age is not advised. And for intermediate and major surgeries, only for patients above 50 years, we are advising. So above 50 years is a cutoff for X-ray, only for intermediate and major surgeries. And with respect to ECG, of course, Dr. Umesh has told again already, but again restating that for patients above 45 years, for minor and intermediate surgeries, and all patients undergoing major surgeries, we have talked about the ECG. The reason was discussed already, and again I am repeating, mainly because the Indian data shows that there is a great increase in the incidence of cardiovascular diseases in India as compared to rest of the world also. So we are also getting to be the capital of the cardiovascular diseases apart from diabetes. So that is the reason which made our experts and our group to decide upon these age timelines. This I would want all our practitioners to please note. So any other questions from the audience and any inputs or any clarifications are needed, Dr. Umesh would be ready to take up.
Bhaskar, one point, can I
Yes, sir.
clarify?
Yes, sir.
See, I need some question in the question box, chat box, that the consumer forum or consumer commission, see, all these years, there is whatever we want to defend, the anesthesiologist wanted to defend himself, there was no evidence, and it was purely on the opinion taken from our other colleagues or other specialists.
Yes.
But
yes.
now that these guidelines are prepared totally based on evidences available and also the countrywide experts' opinion. So therefore, we can argue in future that this is an evidence-based one, and this is definitely I am following it. You even consumer court definitely will agree if we say that this is an evidence-based one, and also wherever there were not much available, the expert opinion was taken and scientific method was followed. This we need to convince the consumer court. I'm sure they will agree with the whatever the guidelines we have made, provided you follow the documentation properly.
Yes, yes, definitely. I strongly agree with your. This is very helpful for our practitioners now. So consumer forum would be definitely in a position to accept the guidelines which are currently formulated. As you said previously and currently also, they take the opinion of the seniors in the specialty. So now we can say that, of course, seniors would also become familiarized with our guidelines, and we can also argue that these guidelines are available and our practice is based upon these guidelines. That is true, sir. Perfect, sir.
Anesthesiologist can straight away present the guidelines to the court.
Yeah.
Yes. So the expert opinion might not come into play when we have these guidelines. Once we have reduced the guidelines in the court, so and it is universally followed by the members of the ISA. Obviously, it is an evidence-based guideline, and even experts, they have to follow the guidelines in the court.
The gray area is when we don't do proper, history taking evaluation and review of medications and investigations. Then over and above these minimum pre-op investigation ordering, something more might have been necessary. If the anesthesiologist missed that, then there can be trouble.
That is true.
Yes.
That is true.
Guidelines cannot be a protection for our failure to examine the patient or failure to take a correct history. These are not the things. But what you have done, you can defend based upon the guidelines. If you have followed the guidelines, there is a definitely differences available, but not a shortcut for failure to take proper
Yeah.
history and the decision making.
I think that is very well said, sir. It
Any other
summarizes
questions
the
are there?
importance.
Right. So, any other? Nice
We have
participation.
so all the answers or questions are answered.
Yeah. I think everybody has good participation.
Yes, sir.
So,
No, actually, the surprise factor was many of the investigations were excluded. Routine investigations that were being done were excluded from the recommendation. So everyone was surprised based on the evidence.
Excluded in the sense
that is
not
why we had lot of
recommended or
questions.
they were not analyzed.
No, sir. Earlier, there was an unhindered recommendation based on individual preferences. Now we have a standard guideline based on evidence. So, and excluding blood glucose.
Was a surprise to everybody.
There was actually a lot of discussion among the experts. In fact, I think we had 3 or 4 meetings addressing this issue. And finally, that's what we understood. See, it is not our domain to use it as a screening tool. Our objective is very clear, whether it alters the immediate perioperative outcome or changes the anesthetic management plan. So when we stick to that objective, there is no need to do it routinely in non-diabetic patients.
right.
Shall we close the meeting, sir?
Kiran, let us assure you that heavy discussion has taken place with the experts across the country. This particular question heavily debated because there were large number of experts who were of your opinion that why we should not do it, but the evidences are against it. Evidences are not in support. I should say that we should routinely do the blood sugar if we are looking at the management. Say, for example, whether it is 150 or 160 or 260. How does it really matter as far as the management of anesthesia is concerned? That may cause a postoperative infection or that may be a different one. But will it change the practice of anesthesia? Probably no. So there was a heavy deliberation. Practically, I think about 4 to 8 hours of discussion only on one point has taken place. And we need to, even I myself is not a supporter of it. But when evidence is not there, then we have to go scientifically.
Yeah, of course, sir. Of course.
So I think we had a nice discussion. Kiran, we can.
I think we shall close the session. So on behalf of ISA Bellary and the WIMS anesthesia alumni, I thank Dr. Umesh for his excellent presentation and sparing